Well, hello and welcome to anyone joining us here in the Hub 1 in this circular setting that some of us are experiencing for the first time. It's a very interesting one. Welcome everyone, welcome to my guest on the podium. I'm delighted to be talking to you and to the rest of the room about brain health, understanding Alzheimer's disease continuum for the next 90 minutes. A little word of warning, this is one of the live stream sessions and I have been confirmed that also the people in the audience can be seen online, so in case anyone is not agreeing with this format, please make sure to leave the room, because there's no way we can actually select who's being streamed and who's not being streamed. Thank you all very much for joining us. My name is Alexia Zurkuhlen. I'm the Executive Director and Chair of the German Council on Aging, in German Kuratorium Deutsche Altershilfe. Our 60-year-old think tank / foundation has been dedicating its work to any issues related to aging and of course over the past 20 years very much so on Alzheimer. Thank you very much for joining me on this round table, the word like quite literally. I'll be introducing my guests and then we'll be receiving the inputs of the four of you before moving on. But actually before the inputs, we have a little game for you prepared. So this is one of the most interactive sessions that you'll probably be attending. And I'll be very, very, very grateful, Teresa, that you'll be supporting with introducing the interactive part of the session. And after that, then we'll go straight back to the inputs of my guests and the moderated discussion. But first of all, let me introduce all of the guests to you. I'll be starting in the order of appearance, as you will be hearing the inputs later. And this is first Dr. Alice Farquharson. You are Senior Director, Global Medical Affairs and Preclinical Alzheimer's Diseases at Eli Lilly in London. Welcome. Thank you for joining us. And then I'm absolutely delighted to have Friederike de Meyer with us today. You are Chair of Dementia Self-Help and caregiver yourself. You are based in Austria, and you'll be giving us the insights from a patient's perspective and from a caregiver's perspective. Thank you for being with us. Next to my right, I have Dr. Katrin Seher. You are a mental health specialist at WHO Geneva. Thank you very much for making all the way here and bringing us some very global insights on the topic. Thank you. And last but certainly not least, Christopher Murray to my left. You are Director of the Institute of Health Metrics and Evaluation. You are based in the United States. Thank you very much also for taking upon you the travel upon the pond and sharing with us some data. So without any further ado, please, Teresa, I'm very happy and, as I said, comforted that you'll be doing the interactive part and introducing the QR code.
So, hello everyone. Please take the opportunity to take out your phones and direct your camera to one of the two screens. There is a QR code, and I can see we have 4 of you that have already successfully done this. Just a request. I think we're going all right. Last time we did this, we suddenly had a problem with Wi-Fi, that everybody was using the same network at once. So I hope that that's not going to be the case here. As long as we keep seeing that number tick up. We'll give it just another moment. However, there will be a QR code on the screen throughout, so you'll have the opportunity to join us along the way in case you miss it in the next moment. Great. We'll call that a critical mass. You can go to start game. So, the opportunity here is that we are going to put ourselves in the position of a minister of health. Imagine that you have been given an emergency budget to deal with the Alzheimer's disease crisis in your country. You have recognized that there is a rising burden of disease, and it's your opportunity to examine the situation and make certain adjustments to the healthcare system to evolve and figure out what you can do about this. Now, you need to refocus the nation's AD policy, and your aides have identified 5 key categories that will have the most impact on outcomes. There's early diagnosis and screening, treatment and post-diagnostic pathways, innovation, care partner support, and public awareness. We're going to be going through a handful of different questions where you'll all have the opportunity to weigh in, and you'll watch on the screen the questions that will come up on your phone. You'll answer accordingly. Make sure that you press continue after you've made your selection, and then you'll be able to see all of the input from the room coming up on the screen. So you can go ahead and press continue there, and then the first question is going to come up. Now, there's also a ticker going down at the bottom, so start getting nervous. You've only got about 65 more seconds for this one. So essentially, you're looking at a budget of, you started with 20 units, let's say, and you need to slide the different things to say where you want to put your budget. So if you've already done this and pressed continue, then you can look up on the screen and you'll start to see, as different people are inputting where they want to spend their money, you'll see that this keeps updating. Once again, these key categories are early diagnosis and screening, treatment, post-diagnostic pathways, innovation, care partner support, and public awareness. I've only got about 10 seconds left, so make sure to make your selection and press continue. And if anyone's just joining us, on all of the screens, there'll be the QR code on the lower left corner of the screen, and you can scan that and join us at any time. All right, time is up. This is where we're at now, and you just see this for a moment, and then when we're about halfway through the game, we'll kind of check in. So you can go ahead and press continue to get us to the next one. Now, your prioritization has created forward momentum. Aides have suggested launching a rapid response policy to capitalize. Continue. This is just a one question. Your prioritization has created forward momentum. Which early initiative will you greenlight to sustain momentum? Make your selection and then press continue. And so now as we're going along, you will see once again the ticker at the bottom counting down the time. And the answer will probably toggle and change as more people weigh in. The options here are accelerate rollout of blood-based biomarker testing in pilot sites, or launch a centralized Alzheimer's disease public education portal. Which one do you want to spend your funding on? About 10 seconds remaining. If you folks want to slide in, there's more chairs over here. All right, continue. There's a care partner crisis. A new national survey reveals the burden on unpaid care partners is growing, with rising need driven by an aging population. Your aides warn that the burden is only expected to worsen. Will you pivot to address care partner concerns or invest elsewhere? Make your selection here of either we need to address care partner concerns or other areas need more investment. Make an option, make your selection, and then press continue. Several seats still available on this side, a bit further from the door, so please slide in if you like. About 10 seconds left. Okay, press continue, please. All right, we're at the halfway point. So, if you take a look here, these are the two categories that we've done the most and the least with. The best being early diagnosis and screening. Your focus on early diagnosis could set a new benchmark for a more proactive and impactful approach to AD. However, we've not done a great job in focusing on public awareness. Awareness remains limited and stigma is high. More focus on improving awareness could now unlock greater service uptake later on. I'm not going to go through all of these. We're going to take a pause from the interaction with the game and move on to our speakers. And the idea is that when we're done hearing what everyone has to say, we're going to play the second half of the game and see how maybe that's have changed some of our perspectives. So, thank you.
Teresa, you can move my handbags. It's one more thing. Thank you very much for everyone also participating and taking the time to answer those questions. Now, before we move on to Alice, I wanted to pin out one thing. So KDA, Kuratorium Deutsche Altershilfe, my organization, had the great pleasure to cooperate with Lilly earlier this year. We had an event here in Berlin also on the early diagnosis and prevention of Alzheimer's disease. And there's a white paper, which I only have printed out once, and it is in German, but it will be available online very soon. And actually, so that white paper was also prioritizing the next steps in this domain, and number one was early diagnosis. So it's very short. It's only 2 pages. I'm sure DeepL or ChatGPT can, or Google Translate, no ad, can actually deal with that. And so kda.de, I'm sure it will be up very soon. Please feel free to check it out. Alice, now we're very much looking forward to the medical side of things.
Thank you. I'm going to move over to the slides, if that's okay. Okay, so good afternoon, everyone. I'm sorry for those who have to turn around. We've got a bit of an unusual setup in here today. As Alexia said, my name is Alice Zurkuhlen, and I'm the Senior Director of Global Medical Affairs for Preclinical Alzheimer's Disease at Eli Lilly and Company. I'm delighted to be here today to provide you with an overview of the Alzheimer's disease continuum and discuss the implications for early diagnosis. Next slide, please. These are my disclosures. Alzheimer's disease represents one of the biggest healthcare challenges of our time. In 2019, it was estimated that there were 57 million people worldwide living with dementia, and up to 80% of these cases are attributable to Alzheimer's disease. It is the 7th leading cause of death in the United States, the leading cause of death in the United Kingdom, and prevalence is increasing dramatically, with estimates reaching 153 million by 2050. And this is not limited to the Western world, but is a truly global healthcare issue, with regional estimates detailed on the slide. Next slide, please. Alzheimer's disease is a relentlessly progressive neurodegenerative disease characterized by pathological changes that may begin in the brain many years before the onset of cognitive and functional symptoms. The pathogenesis is complex and multifactorial, involving multiple pathological processes: the deposition of amyloid beta plaques within the brain, the formation of neurofibrillary tangles from hyperphosphorylated tau within the neurons themselves, and neuroinflammation. And these collectively result in disrupted signaling and function of neurons, and ultimately widespread, irreversible neurodegeneration. Over time, this neurodegeneration eventually translates into the clinical syndrome of Alzheimer's disease that we are familiar with. Cognitive impairment, like memory loss, confusion, impairment of executive function, reasoning and thinking abilities, language difficulties and mood disturbance, and also functional impairment, which progressively worsen as the disease progresses, eventually impacting the individual's ability to perform even basic functions of daily living, such as washing and dressing, and necessitating full-time care. And as anyone with first-hand experience of Alzheimer's disease will know, Alzheimer's is a truly cruel disease, which robs people of who they are, not only their independence, but also their memories and their relationships with family and friends. And up until very recently, treatment options have been very limited. Clinicians have been restricted to symptomatic treatments, which are unable to impact the progression of the disease and have no impact on the underlying disease biology. Next slide, please. Our understanding of the science underpinning Alzheimer's disease has, however, improved considerably over recent years, and it's now recognized to exist on a progressive continuum involving distinct stages. Although there is differing opinion internationally about how best to classify the very earliest stage of preclinical Alzheimer's disease, which you can see on the slide in grey, or stages 1 and 2 as per the Alzheimer's Association, there is consensus that Alzheimer's pathology precedes symptom onset by many years. During this stage, individuals have evidence of amyloid beta pathology within the brain, which can be detected using biomarkers, so either positron emission tomography, imaging, or cerebrospinal fluid sampling. But these individuals are predominantly asymptomatic at this stage, only with very subtle cognitive or behavioral changes, if any. Objective cognitive impairment then defines transition to the next stage along the continuum, to Alzheimer's disease with mild cognitive impairment, or stage 3. With increasing cognitive decline and functional impairment as an individual progresses through the later stages of the continuum of mild, moderate, and finally severe dementia. But this earliest preclinical stage provides us with a valuable window of opportunity to potentially detect Alzheimer's pathology prior to significant neurodegeneration taking place, whilst individuals still have preserved cognitive and functional capacity. Next slide, please. So moving on to think about clinical practice then. Historically, we've relied solely upon clinical assessment for the diagnosis of Alzheimer's disease, involving memory and cognitive tests. But these have inherent limitations. The early changes of Alzheimer's can be subtle and non-specific, with considerable overlap with other dementia subtypes, resulting in a misdiagnosis rate of up to 30%, even when used within a specialist setting. The incorporation of biomarkers, however, into a combined clinical biological diagnosis enables us to be much more precise in our diagnostic practice, capturing both the symptomatology and the underlying pathophysiology. Additionally, this approach facilitates diagnosis and intervention at a much earlier stage of disease, with the evidence suggesting that doing so is likely to confer greater benefit to patients. Despite there being significant advances in Alzheimer's diagnostics, notably the recent FDA approval of the first blood-based biomarker for symptomatic Alzheimer's disease, there is still some way to go if we want to shift towards identification of the very earliest preclinical population. This is a novel area, so preclinical Alzheimer's disease is not yet recognized as a stage of disease in clinical practice, with no associated ICD-10 code. There are no guidelines, recommendations, or consensus statements on appropriate diagnosis at the preclinical stage, and there are no approved treatments or management guidelines, although clinical trials of therapeutics in this population are ongoing. Next slide, please. And finally, I wanted to wrap up with a vision for the future. Firstly, widespread recognition of preclinical Alzheimer's disease as a stage of disease, and also recognition of the value of detecting pathology at this earliest time point. Secondly, increased awareness of the importance of brain health and prioritization of brain health discussions within clinical practice, destigmatizing cognitive complaints, encouraging patients to present at the earliest opportunity, and encouraging healthy behaviors. Personalized Alzheimer's disease risk assessment, including age and family history, to appropriately triage individuals, and a shift towards earlier diagnosis utilizing blood-based biomarkers, which offer a more accessible and scalable alternative to traditional PET imaging or CSF testing. And finally, personalized care, dependent upon the individual and also the stage of their disease. A holistic approach, optimizing comorbidities, making lifestyle modifications, and ensuring that patients have access to innovative treatment options and the knowledge that they need to make informed decisions with their clinician about their care. Thank you.
Thank you very much, Alice, for this very interesting presentation and the focus on the value of early detection itself. Without any further ado, I'll leave room and I'll dynamize or I'll put more dynamics into the discussion after the 4 presentations. But Frederica, thank you very much for joining us today. I understand you'll be telling us a bit more from your very personal perspective, but also as a representative of the patient organization in Austria.
Yes, thank you. Good afternoon. I think it doesn't work.
Is it on?
Should I press the button? It's working? Okay, sorry. I don't hear it. So I'm here today not as a scientist and not as a medical professional. I'm here as the wife of a man who was diagnosed with Alzheimer's disease in his mid-50s. My story is personal, but I think it's universal in what it shows, how subtle the science, the first signs can be, how confusing and how difficult it is to know what to do. So my husband was a very successful civil engineer working internationally. We lived with our 3 children, mostly abroad. A life that was very full, sometimes demanding, but exciting. And around 2013, we then lived in Qatar. I began noticing small but unusual changes. So he became more irritable, tired in the evenings. Sometimes he reacted strongly to very minor issues. While driving, he couldn't keep the lane, sometimes drifting too far left or too far right. And when I mentioned it, he denied it, insisting everything was fine. So I also noticed inconsistencies in the way he told stories. Today I know it's called confabulating. And small routines that seemed odd, like repeatedly buying and hoarding the same chewing gum, or not closing drawers. At the same time, our youngest daughter, who was with us and went to school, was struggling with a severe depression. It was a very difficult period for the whole family, and I could see how much it weighed on him. So in 2015, and I'm telling the story during the time, our youngest daughter was struggling, in 2015, he went on sick leave. My husband went on sick leave because of back pain. And this was the first time in his life that he took sick leave. And it led to a transfer back to Austria. In March 2016, we drove from Qatar to Graz, which is our home base in Austria, a long journey. We drove back by car. And in hindsight, it clearly revealed his growing cognitive difficulties because he couldn't keep the lane. But I did not dare to mention this towards him. And I finally confided in our family doctor back in Graz, explaining my observations. And he suspected mild cognitive impairment, MCI, and referred us to a psychiatrist. So that was the first time in 2016, after 3 years, that I dared to speak out to my husband. So he went. Cognitive testing was abnormal, but yet no further investigations were conducted. We were told he was overworked. Yeah, very typical. Between 2016 and 2018, he continued to work internationally. He changed employers several times, but his reputation preceded him, and he could choose projects in Austria, in London, in Toronto, and finally in Copenhagen. He was often struggling with dizziness. So he went to a neurologist in 2017, and there was an MRT made, but this doctor said, oh, nothing special to see. In Denmark, finally, 2018, dizziness was again so hard that he sought help from a psychologist. And also this psychologist didn't see something. By the end of 2018, I insisted on further testing. And the initial diagnosis was burnout. But because I still remembered the unusual cognitive signs, I arranged a PET scan. And the result was young onset Alzheimer disease. And the MRI from 2017 had already shown indications, but it had been misinterpreted. Yeah, my English is not the best. The diagnosis was really devastating, especially for my husband. And he thought it meant the end. He had very little knowledge of the disease, and only the usual stereotype came to mind. I will forget everything, I will not recognize my family, this is the end, and it will only last 3 weeks. There was no treatment plan, and there was no clear pathway. We were largely on our own. So the sudden loss of his career, the forced stop from work, this was extremely difficult for him, and he sank into a deep depression. Psychotherapy was limited. After only a few sessions, the therapist concluded that a person with dementia did not need treatment. Looking back now, I ask myself, what if I had known in 2013 what I know today? Would I have insisted on testing back then? It would have felt very intrusive, almost impossible to suggest it to someone intelligent, accomplished, someone who had built up a successful career. But our children see it differently today. They would want to know earlier, not just for planning, but also to reduce risk factors and prepare for care. They would invest in health, education, and planning, hoping to delay the disease or protect their own futures, and therefore asked me to let my husband test it if there is a genetic factor. And still, until today, I did not do this, but I will. At the same time, I must mention something practical that has helped us enormously. My husband had taken out a disability insurance policy when he started working in Copenhagen. That was his last working place. Today it provides crucial financial support. Dementia is expensive, especially the therapies and the reality that has come increasingly difficult for me is to maintain my work while caring for him at home. I want to keep him at home and not place him in a care facility. So when I'm not there, like today, there are 2 professional caregivers, and like today. For me, while early knowledge has clear benefits, it also brings a heavy emotional burden. Alzheimer's is still incurable. The years after diagnosis are often challenging, not just for the person affected, but for the whole family and surrounding. And yet our experience highlights a critical point, the urgent need for reliable tools for early detection. Blood-based biomarkers, for example, could allow detection of Alzheimer's long before symptoms appear, as you mentioned. This could give families time to plan, to intervene, to access support, and it could open important discussions about ethics, family dynamics, and social policy. So our story, or my story, is personal, but it also reflects the broader reality faced by many families today. For me, early diagnosis is not only about medicine, but it's also about dignity, about planning and human connection. And it is about giving people, patients and families a chance to prepare and to make informed choices. Thank you for having me.
Frederica, thank you very much for sharing the personal journey of your family. And this is, I guess, also one of the key messages. It's, as you said, it's everyone's journey. And I noted down that basically you pledge in to get more time to prepare for care. I think that's thank you very much for that. And we'll be coming back with more questions also from everyone in the audience later. Catherine, you next in line. Thank you very much. Welcome again. So you'll be talking more about, I guess, the international and global perspectives of strategies to address early detection and prevention.
Yes, thank you very much for having me. It's a great pleasure. It's also a big challenge coming after Frederica. But yeah, my role on this panel is to take a policy, a global perspective, reflect, like Alexia said, what we as a global community can do to address this clearly pressing and complex challenge to public health that comes with Alzheimer's disease and dementia. I'm not going to repeat some of the numbers that Alice has shown. I'm sure Chris will also give you some more numbers. Maybe just for context, dementia is not actually a condition that is primarily residing in high-income countries that are super aging. Already today, 60% of all people living with dementia live in low and middle income countries. And there are countries, societies that have even less infrastructure to provide timely diagnosis, care and support. So I think that's really important to keep in mind. And then the other thing, and Frederica has done really an amazing job, is in reminding us that these figures are not just statistics. These are real people. They are people's parents, their partners, their friends, they're maybe your neighbors. They're individuals and families trying to really navigate uncertainty, as you heard from Frederica. Their caregivers struggling with different responsibilities, trying to make everything fit. But they're also communities striving and trying to do their best to provide support. So much more than just a global or public health issue, dementia and Alzheimer's is also a social and economic and a gender equity issue. The global costs already run into the trillions. The bulk of cost is provided by family members, so informal carers. 70% of those are women. So here comes the gender lens. And many carers provide that support without any carer support or formal training. They're thrown into the deep end, so to speak. They don't receive financial compensation for the work they do, or the service to society that they do. And they often don't have access to respite services. I'm really glad that Frederica has the support so that we can all benefit from her experience, but many people around the world don't have that. So when we talk about supporting people with dementia with policies, that always includes also supporting or creating infrastructure for the carers. And when we talk about addressing dementia, it means also addressing the inequalities that surround it. So how do we do this as a global community? Member states took a very bold and crucial step in 2017 when they adopted the Global Action Plan on the Public Health Response to Dementia. And my role at WHO is actually supporting member states in implementing it, whatever that might look like at individual country level. Then earlier this year, member states had said, okay, we need more time. They've extended it for 6 more years until 2031. And we're now, today, starting planning with countries on, what are the next steps. So the plan gives us the framework. It outlines targets. It makes suggested actions for member states, but also WHO or other partners. And we monitor global progress using what's called the Global Dementia Observatory, or GDO for short. And we can use that also to identify gaps. See, where are the pain points? Where do we need to move faster or accelerate our efforts? Before I give you a few insights from the GDO data, I just want to quickly share that WHO is one of our key activities or responsibilities outside from monitoring is also developing norms and standards to help countries create better responses to dementia. And some of these norms and standards are guidelines for dementia diagnosis, treatment, and care, specifically in non-specialized settings. So we have those already. We're currently updating our guidelines for dementia risk reduction. This is a very important policy area to drive forward. And last year we published what's called preferred product characteristics for blood-based biomarkers for Alzheimer's disease. So that's also very pertinent to the discussions today in how we prepare health systems in rolling out these blood tests. But when we now look at what our member states tell us through the Global Dementia Observatory and how they're progressing in responding to dementia, we now have 100 countries participating in the GDO. 60% of them are low and middle income countries, so we're fairly representative of the overall situation. But only 1 in 3 countries can report on how many people are diagnosed with dementia. So that gives or indicates huge gaps in monitoring and surveillance. Imagine those poor numbers for infectious diseases. Even worse, only 15% of countries routinely monitor people living with dementia. So major gap is in surveillance and health system readiness. Our member states also tell us that about 2/3 offer some sort of community-based services for dementia, which is not, it's okay, But, here's the but, these services are not distributed equally in a country. So when it comes to diagnostic services, for instance, they're often limited to the capital or to major cities. If you live in a rural or remote area, you can't access them. In fact, only 43% of countries have them also in rural areas. And similarly, access to diagnostic services, when you look at who provides that, kind of like is that a public or a private health sector service? In low and middle income countries, only 22% of countries have this covered by the public health sector. So that raises concerns about equity and financial burden of people living with dementia and their families. Carers, we've already touched on the critical role that they play. Only just over half of the countries provide any form of carer support. That's shy of the 75% that we want to reach the global target. And again, the issue here is that these services are not available across the board in a country. So if you're in a rural or a remote area and a low-income country, you have basically less chance of receiving any support. So these figures tell a clear story. We're definitely not there yet. We have a lot to do over the next 6 years, but they also tell us or show us where to act and where to start working. So the key focus area for us is strengthening primary care and community-based services to increase access, to have access more equitable when it comes to diagnostics, but also care and support the carers because they keep the system running, and invest in data systems to enable countries to report better, to generate the information they need for decision making. So the Global Dementia Observatory, in closing, it gives us the evidence. The action plan is our roadmap, but what we now need for this next 6 years is the political will, which member states signaled to us, the sustained investment and collaboration across all different stakeholders. This is, like I said, it's not a health issue, it's not a WHO issue, and it's not a government issue alone. Coming together to kind of really make it happen. Thank you.
Oh, thank you. Thank you very much for also wrapping it up towards the end and really putting those few words forwards of increasing access and equity, both to the early detection, early diagnosis, but obviously also to the support, including family members and carers of all sorts, and the community approach. Thank you very much for those insights and sharing the roadmap for the next few years at WHO. I'm turning to Chris. Chris Murray, thank you very much. I believe you do have a presentation as well. Would you like to?
I do. There we go.
Brilliant.
So I am going to try to address what is the current and future burden of Alzheimer's disease. How can we model out the impact of either existing or potential future intervention strategies? And what are some of the other critical questions in thinking about the broader brain economy? So just a word about our perspective, and that's coming from the institute that I lead, which is the Institute for Health Metrics and Evaluation. We're about 500 people, primarily based in Seattle in the US, but we run a very large collaboration for the global burden of disease work, which has more than 17,000 participants in that collaboration from 167 countries. We try to produce what we call global public goods, which is analyze the epidemiological data for every disease and injury and 80 plus risk factors, make that freely available online in journal articles, data visualizations. And then we also do a lot of specific modeling of both forecasting into the future and then intervention strategies that might alter the trajectory for different diseases, including, as you'll see, for Alzheimer's. So we have had a brain health initiative for a number of years. And the idea behind this has been a series of organizations have funded more intense work on Alzheimer's than we do as the standard part of the global burden of disease and what we call future health scenarios, our forecasting program. And you can see the list of organizations that have funded this work. Quite a bit of this has been diving into some of the economic aspects of brain health, putting our analysis around burden in one place, and also publishing and using the forecasts around Alzheimer's. If you're interested in the Brain Health Initiative, you can go to brainhealthatlas.org, and that'll give you more information on the results. And of brain disorders more generally, in 2021, when the Atlas was first launched, we had more people suffering from brain health conditions than cancer or cardiovascular disease, and that's projected to increase to a very large number by 2050. In the published forecast, and you can see the citation in very small letters on the bottom, we forecast that for a number of drivers, which we'll come to in a moment, that prevalence is going to steadily, but actually have an accelerating rise out to mid-century. And you can see the number of millions of cases that with, of course, uncertainty. And in 2024, on the right panel, you can see the prevalence of Alzheimer's, all age prevalence. So this, to a large extent, reflects the age structure of the population, but not just. Now, what's driving this huge increase that you see on the left upper panel? Population growth, part of it. Aging, huge part of it. But some of the risk factors that we know about that are associated with increased Alzheimer's disease is also driving up the prevalence as shown. So more people with high blood sugar, increasing smoking rates in some regions, think sub-Saharan Africa, and then increasing obesity rates are some of the other risk factors that are going up. Some risk factors are lowering it, for example, rising educational attainment, which is one of the more powerful risk factors. Now, the global increase in disease prevalence has very substantial economic effects, and we've done quite a lot of work led by our economic analysis teams at IHME, trying to look at both direct spend on Alzheimer's and then the costs for foregone work and then informal care. And so if you put those components together, on the left-hand side, direct spend of $205 billion today, and then projected increase because of that huge increase in the number of cases and increase in spend per capita. So you put the two together and you find out that there'll be 1.6 trillion with large uncertainty intervals, but still a very large number in 2050. And on the right-hand panel is the informal care component, which we have looked at all the published studies and a number of time use surveys that tell us about informal care in the household. And that's estimated at $350 billion, and that should increase to about 0.9 trillion. So very large numbers. And on the left-hand map, you can see that per capita spending, as you might guess on Alzheimer's, is highly related to age structure, but also just generally those health systems where health expenditure is very large. Think the United States or Norway as an example of that. On the right-hand side are 5 countries showing where we have more detailed analysis of the direct spend. And what's interesting about that is it shows that across France, Germany, Japan, Switzerland, the US, these are places that have followed a similar protocol on looking at disease expenditure by disease and age and sex, that where Alzheimer's spending is primarily located varies quite a bit across location. So for example, in Switzerland, most of the spend is in nursing facilities, whereas in Japan, most of the spend is in inpatient facilities. Now, the economic burden in the future is driven, as we've said, by many factors, but aging of the population, the demographic shifts that we know with relatively small uncertainty, because most of the trajectory of population, even towards the end of the century, is driven by events that have mostly occurred, reductions in fertility, for example. And on the left bottom panel, you can see an example from Germany of population age structure becoming this inverted pyramid as we go out towards the end of the century. And you know, we will enter this phase in many parts of the world, in fact, pretty much everywhere outside of sub-Saharan Africa, where there will be more people in the age group ahead of you than behind you. And that's just driven by below replacement fertility that is happening in half the countries of the world today and will progressively expand to most countries by mid-century. Now, on the bottom right is again a case example for Germany, which is spending per case on healthcare and informal caregiving for dementia, where we expect the direct costs to really increase rather substantially. And then the informal caregiving is going down here, but that's a function of which country we're looking at and the composition of caregiving. So countries and healthcare systems, I think as we look into these forecasts, are not really ready for the challenge imposed by Alzheimer's disease. So if we really want to help governments and societies and organizations in society prepare for what's coming, we need to demonstrate the urgency of the challenge, advance scientific breakthroughs, we hope, early diagnosis, better treatments, you know, as I'm sure everybody's watching, there's trials out for new therapies. Scale up evidence-based interventions, ensure equitable access, change delivery systems so we figure out what's the best way to take care of patients in the way that they and their families would prefer, and develop thoughtful policy that puts brain conditions and their families in the center. And we believe, which is sort of why we do this sort of work, that better assessments, better forecasting can help us all be empowered to act on Alzheimer's. One of the things that we're looking at is the evidence base around and the both health and economic effects of existing interventions and hypothetical interventions, in one way or hoped for interventions. And one of the strategies we use for this is using microsimulation. So we can create, using the epidemiological data from the global burden of disease and from our forecasting, credible microsimulations of the population, so you can test the question, if you had an early diagnostic and if you had better therapies to slow progression, what would be the health and economic effects, and do that on a location-by-location basis so that you can try to give decision makers simulation studies that can inform what they might do and what the benefits might be. So many questions come up from these analyses, you know, and I think it turns us back to the general question of how can you increase investment to support current patients, at the same time investing more in potential innovations that can alter the future trajectory. Even if you have, quote, cost-effective interventions that might meet some threshold of GDP per capita that people use in the cost-effectiveness world, governments may not be able to afford that because they may not be spending much on their health budgets. And so what can one do to help bring attention to underfunded systems? And then this whole question of the trade-off between the fact that the benefits from preventing, let's say, through risk factor modification, Alzheimer's come in the future well beyond the traditional time frame that some decision makers in health systems or ministries of finance may be thinking about. You know, the classic problem of the benefits of prevention being too far in the future. So for those who are interested in the publications that support these sort of analyses, there's a long list there, and you go for resources online.
Great, thank you very much, Chris. Thank you very much for pinpointing in particular I mean, I had the opportunity to look at some of the resources from your institute earlier, and so some of those numbers were known to me. However, I always find it fascinating, that slide or the information bit about the differences in recipients of depending on the country. So it might even be an equal spending proportionally to GDP, but it might actually go to very different recipients in healthcare. Let it be also support to the community, support to, or you know, and a focus on health literacy, or a focus on therapies. Is there something you'd like to extrapolate on that, or? Because I would love to hear some more. Maybe I like, could you rank them? Could you say, well, there's best in class, or is it a proportionate balance in those different type of recipients that might be the key of it?
So that sort of analysis, and this is, you know, primarily the work of Joe Dielman and his team at IHME. And if you're interested, you can see this incredibly detailed analysis for the United States. And now they've brought it down to the county level, so you can actually look at spend by disease at a super granular level. Unfortunately, we don't have that for a lot of countries. I showed some on that other countries have adopted Joe's protocol, and so we have comparative numbers in some places. But it's really hard to think about the economics around health systems and healthcare for any disease, and especially for Alzheimer's, when we have only got that sort of really detailed information for a limited number of places. Mm-hmm. And we keep trying to encourage other countries to, you know, follow that protocol so you can understand where the money goes and figure out how to spend the money more wisely.
And that was my official question to you, because that was just piggybacking what you just said. But like, so what type of data would you love to be gathering in order to have an even better evidence base for further responses?
Well, there's the epidemiological data, and many people can speak to that. You know, one of the things that we find a struggle on Alzheimer's is there's more than 200 different instruments that are used to measure prevalence, and so it makes the task of making sense of the data really hard. It would be great if there was a smaller number. But on the economic side, you know, the way to understand where money goes is you need to have information on different types of providers. You know, where's the money going, and then detailed utilization data to try to sort of take the bundle of money that goes, let's say, to nursing facilities and say, what diseases is that for? It's a very doable task. It's just that it is not information that often health system leaders think about it as a top priority. They usually are more focused on the epidemiological data, less on the economic data.
Well, thank you very much. I'll go on and open the round of discussion. I'll jump back to Katrin, because it was also about, you mentioned also the monitoring that some countries are already pursuing, and some others may not. So what would be like, would a lesser number of indicators, of tools, or in the monitoring examples that you mentioned, is there also a blueprint that like any countries in the world could actually use in order to monitor?
So we do have the Global Dementia Observatory. There are 35 indicators, 19 of which are produced or submitted, or the responses are submitted by member states. One of them is, for instance, dementia diagnostic rate, which is our global target for the big action area on diagnosis support. I've mentioned it's really tricky, and countries do, like Chris said, they don't collect that kind of information. I would love for them to be able to not run an epi research project to report back the number of people with dementia in the country, but have those figures available at the fingertip. Going forward, I'd also love for them to be able to disaggregate those numbers, because right now, I mean, they're already struggling to provide those numbers. We don't necessarily know, for instance, the severity stage at diagnosis. When we're now talking about or calling for earlier diagnosis for Alzheimer's disease or dementia, it would be good if over time we could actually show that the number of mild dementia or even pre-symptomatic kind of grows, whereas the detection or the rate of later stage dementia goes down. But right now, not many countries are in a position where they can do or monitor that kind of information. The same is true for not just severity, but also pathology, for instance. So for the longest time at WHO, we've said, well, just report any kind of like dementia. Like we know that if we rely on clinical diagnosis, Alzheimer's disease is often not accurate or perfectly accurate as is. But biomarkers will change this. So my hope is that countries going forward will be able to also disaggregate or report those figures, and we then just have the information at hand that we need in order to plan services and need for treatment and so on. So, yeah.
You started your impulse by mentioning that obviously there was 60%, I believe, of patients undiagnosed. People with dementia living in LMICs, which obviously is due to a number of factors, but there is that the crucial question of how do you drive the early diagnosis forward at that level. So leaving the policy level to go to the early diagnosis level for everyone on the ground. And again, and this is something that is common to every country and to every person and to every family. There's still that fear of actually not wanting to know. I think we heard that this morning in a session, and also of stigma associated to that. And I'm turning to Alice. I think what messages would you like to see conveying to people, to patients, to the broader public, in order to facilitate that shift towards early diagnosis?
Yeah, thank you for the question, Alexia. I think it's a really important issue, because we can do whatever we like to transform infrastructure, patient pathways, educate healthcare professionals about the importance of early diagnosis, the role of biomarkers. But if patients aren't presenting at an early enough time point in the disease course, then we're not going to achieve this goal of moving towards earlier detection and diagnosis. So I think there's definitely work that needs to be done in terms of public health messaging about the importance of brain health, what it is, to really give individuals the tools that they need, the knowledge, in order to be able to look at their risk factors, their lifestyle, like some of the things that Chris referred to, in order to mitigate their potential future risk of developing symptomatic Alzheimer's disease. I think there is a bit of a myth out there in the public consciousness that Alzheimer's disease is predominantly genetic and that there aren't any meaningful treatments. And therefore, I think that's kind of fed into this reticence, perhaps, to present to clinicians at an early time point. Whereas I think that we really have a responsibility to educate the public about brain health, about the modifiable risk factors for Alzheimer's disease. You know, if you have diabetes, the importance of optimizing your glycemic control, of controlling your blood pressure appropriately, and all of the same messaging for heart health that was such a successful drive in terms of the public consciousness also applies to brain health. So I think, we've seen that it's been done before. I think we just need to get it out there into the public consciousness in order to empower the public and future patients with that knowledge to be able to make lifestyle modifications, but also to be able to go and seek help at the very earliest opportunity.
Thank you. As a medical doctor, when you hear the story of Frederica, someone with such a determination and awareness from the very early stages on, seeking actually advice from the medical side, and still, I believe it was 5 years in total, really, until you got the final diagnosis. That must be terribly frustrating, because especially for someone like you working at the peak of innovation and making sure that the messages are heard. Before we turn to you, Frederica, is there like one more message that you would like to say? Okay, because now you just mentioned also the public awareness, and so the more public or general audience health literacy on the matter, brain health literacy. What if you were talking to your fellow colleagues who are the GPs on the ground at community level?
Well, exactly, that's the other side of the coin. We also need to educate and upskill clinicians as well. And Alzheimer's is a tricky one, that it's not covered by just one specific stakeholder group. It depends on the geography. So, it can be neurologists, old age psychiatrists, sometimes geriatricians, primary care physicians also have a role. So targeting that education can be challenging as well. But unfortunately, this sort of story isn't uncommon. And it points to a bigger issue, that there's been a real lack of urgency, not just on the side of patients, but also on the side of clinicians, that perhaps there isn't such a rush. If it's a progressive disease, there aren't a huge amount of treatment options. They don't have access to biomarkers. So unfortunately, it's not uncommon, but I think it's a mindset shift that we can and we should change over time with education and messaging, and also, the advent of blood-based biomarkers to make it much more accessible. And overcome some of the issues that we've had with PET and CSF testing, which are less accessible.
Federica, you made it very clear earlier that I think one of the greatest fears also for even though you had those, you had interpreted those first signs and you had questions, but you didn't actually mention them to your husband. And then when you did get the diagnosis, that this black and white, you shift from being a person to being a person with dementia. You shift from into something where you said, there was no treatment, no pathway. It was the end of the career of your husband. And is that the issue, this black and white? And how did you encounter it yourself in your personal journey? And what is the key message that you are conveying at the organization level?
So you mean the black and white?
How do you overcome that fear of actually becoming a patient?
Yes.
From being a person to becoming a person with dementia.
Well, in opposite to myself, my husband did not care a lot about this theme before. Yeah, he was working and he was successful. And what I know is the more education years you have, the longer the studies, the later you get your diagnosis, because you can hide it. Yeah, and with your intelligence, well, that's what I heard. And in the case of my husband, maybe it was like this. But what must I say? The black and white, after the diagnosis, well, I have to think about it. It's a question I haven't thought about. Yeah.
It's true that I didn't mention that question in advance to you. I was just equally, because it's really that shift, isn't it, from not knowing to knowing.
Yes. It leads you in a deep depression, and I think even early diagnosis leads into, well, as far as I know from people I know, it always, very often, not always, but very often it leads to deep depression, especially when you're younger, when you have this young onset dementia. Maybe not when you're in your 80s or 90s, but especially when you're diagnosed more early. And I think you need this professional guidance. This is very, very important. But I wanted always to say that knowing about risk factors, that does not automatically mean that it leads to an action. I mean, changing habits is something we all know is not easy. And yes, we were lucky. I mean, if you have less education years, and if you are a woman, then it is much harder to get support. Yeah. So, yeah.
Also, did you find the help you needed at community? I mean, you've been mentioning also traveling for work a lot.
Yeah.
So how easy was it for you to find that so necessary support at community level?
You know, I heard something in the beginning from a friend in Copenhagen, and she said Alzheimer's hits the whole family. And what I must say, and needs a network. And this is something I was used to do. Living abroad, you always need a network. Yeah? And this network is family and friends and doctors and carers and therapists, but also personal assistance is very, very important. Because many people in the future will live alone with this disease. They don't have their family next to them. We live in Austria. Our family is not living in Austria. Yeah. So, but this network should communicate and coordinate, and it's not easy for us. For me, it was not that difficult, but I understand that it is very difficult for others to have this, to know about, and how to spin this network. Yeah. This needs guidance.
You mentioned the fact that even knowing about risk factors did not necessarily or immediately lead to changing behaviors. Chris, I'm turning to you. What are effective policies for better prevention? Or what are the numbers that actually then, can provoke better prevention policies?
I think that you have to start with identifying the risk factors. And as part of the GBD, we have some risks for dementia. We're expanding those quite a lot through systematic reviews and then trying to analyze those. Unfortunately, there is for some risks that people assume are important, there's very few studies, right? So there's a lot of data sparsity. Take alcohol and dementia, which I think most people think there's a strong relationship. Well, the number of studies is so small, it's really hard to actually assess that risk curve. There are some things which we know are super strong, education being the strongest risk factor. And I don't think it's just, or at least we think it's not just that you're better able to mask the symptoms. It seems like there's actually a protective effect, quite a strong protective effect through education. So that's pretty compelling. There's some of the newer risk factors. We've already talked about blood pressure and blood sugar. Air pollution turns out to be another powerful risk factor. We've added that to the GBD this cycle. And There's a number of other putative risks that are being evaluated. There's, of course, a lot of discussion about 2 vaccines for which there's not trials, but there's pretty convincing observational studies. You know, herpes zoster vaccine and RSV seem in multiple studies to have a 30% reduction in risk, so that's enormous. So there are a number of prevention strategies, for example, in the case of vaccination, and then in the sort of growing list of risk factors. I think if, even though it's hard to change behavior, there's something about dementia that is very scary to families and people. So I think making sure that people understand the risks, that you can actually modify your risk, and if in aggregate across those risk factors, it's quite a lot. It's not, you know, genetics strictly at all. There's a lot of scope to reduce your risk. And this might actually help have knock-on benefits because people really are probably willing to change their behavior to avoid dementia risk.
Thank you. Catherine, if we look, because I love the fact that you have just those comparable figures about different, you know, the different countries and also the policymakers, but also the stakeholders in all those different country settings. Who are the most relevant stakeholders to go talk to if I want to change something in terms of, let it be dementia awareness or the policies on early diagnosis, the increasing health literacy, or the access issues to diagnosis and treatment?
Well, after having worked in this field for I don't know how many years, I'd like to say the usual suspects, but this is probably an unsatisfactory response for this audience. So of course you need to have the policy makers kind of like get them on board and kind of like educate or raise awareness that this is important.
So despite of closing this door, and now that we're all here, like what else can we do instead of trapping them into the World Health Summit 2025 and ongoing for the next 10 years?
So you usually you present them with the facts and the figures, which I think we've all heard of. That usually helps you to make a compelling case. You need the support of academia and clinicians, health professionals. Of course, in many countries, policies are driven and first developed by civil society. That comes from that huge advocacy history and efforts that you see at country level. So I would always bring them on board, and many national dementia responses that are formulated have built on what either civil society had done before, or at least have them as strong partners. You need industry, you need media. It's really a multi-sectoral approach. But I kept the most important group for last, just because I also want to have that sink in. You need to have people with lived experience, so people living with dementia and their carers involved in every aspect of the prioritization, the development, the monitoring, the evaluation. It changes the discourse entirely if you have a person who can, like Frederica, tell their own experience. And it's for that reason that in that latest GDO data collection round, we've actually added indicators that say, okay, to what extent have people with dementia, not in a tokenistic point of view, kind of been involved in country X policy development, and then also the implementation and the monitoring. And we do see that this is starting to sink in, being implemented by more countries, and will hopefully also have a huge impact on the quality and kind of like what actually then gets implemented and ultimately fed back or implemented to the benefit of those who need it.
Yeah. Thank you. Alice, earlier I asked that question also, mentioning your medical background, but you're also representing a very innovative company. You're here today from Eli Lilly. And what would you say are the challenges bringing innovations onto the market? What do you see as, the hurdles and or the main things to overcome?
Yeah, thank you. I'm smiling because it is a significant challenge. I think we've already discussed about some of the existing challenges within clinical practice, and there's still a substantial gap between research, clinical trials, and what's happening in terms of Alzheimer's innovation, which is accelerating, compared to what is happening on the ground with patients and clinicians the majority of the time. So it presents a real challenge when you're then trying to translate what is done within this setting into a completely different sort of real-world healthcare system, which obviously differs by geography as well. But we have tried to be really intentional with our trial design, with our ongoing trial, by incorporating the use of blood-based biomarkers, so plasma p-tau217, as an alternative to amyloid PET scanning or CSF, like in previous trials that have been conducted, because we see this as being much more patient-friendly, much more clinician and healthcare system-friendly. We've discussed some of the challenges with PET and CSF. So that's the first thing. But then also, secondly, assessment of cognition. So we've really sort of leaned into remote assessments in the trial, hoping that this is something that may be translated in clinical practice, therefore relieving burden on healthcare systems. I know that there's a huge amount of research at the moment into digital cognitive assessment tools, which are really exciting, and also a way of patients potentially being able to assess their cognition at home, being able to track it over time, and being able to present that data to a clinician, therefore relieving some of the burden on the healthcare system.
So again, despite the disparities of different health markets, go towards the most accessible ideas and patients, and basically taking on board the recommendation that we just heard, involve the patients in terms of having them participate at the very early stages of diagnosis. I'm aware that we don't have much time left. There's two things that we need to do. We want to do the second part of our Alzheimer decision game. But before that, I'd like to open the mic I would collect around about 3 questions if we have them. I have already 2 hands up, 3. So there we go. Yeah, perfect. I'll take them. I'll take them all together. I'll take 3 together. Maybe state your name, your organization, and very short question. And if you have one particular person you'd like to address it to, please also state their name.
Hi, I'm Dr. Brittany Barretto. I am a women's health expert, and I don't know why women wasn't mentioned even more today, because 2/3 of Alzheimer's patients are female. I'd also like to ask the 3 panelists why you didn't mention hormone replacement therapy in menopause, because hormone replacement therapy in several studies have been shown to reduce Alzheimer's by 30 to 50%. So why wasn't that mentioned today as a preventative?
Thank you.
Thank you very much for the chance. And I'm Vansh Yadav. I'm a medical student in University of Nairobi, Kenya. So my question is, I'm only allowed 1 question, so I'll try to summarize it as much as possible. And I think I'll ask all the panelists. So all the data we were shown a few risk factors like low levels of education, let's say environment, and also the low levels of education, environment, and genetics, other than that, life factors. So I had a question. Let's say when we looked at the map, most of the cases, the Alzheimer cases and dementia cases were in the global north, where they have better, let's say, air quality, better food quality, and better also education standards compared to Kenya or let's say India. So my question was, either the data that was there, was it age-related? That's why it was showing that it's more in the global north since they have the higher median age, or was it because there's a factor that there's a research I read that said if you have increased hearing loss or visual loss, that increases chances of dementia. So do you think maybe also getting putting people in a pressure cooker and they are studying, they end up having other health problems, that increases the chances of dementia? So is it that, or what is the difference in the demographic regions?
Okay, thank you. I had the lady here who was very quick in raising her hand.
Thank you so much for the opportunity. My name is Anin. I'm from International Federation of Medical Students. I'm from Indonesia. I would like to ask a questions about what the panelists already said before. Alzheimer care goes beyond the medicine. It requires awareness and also community support and cross-sector collaboration that has been mentioned. So my question is, how can the actual action, the governments and the global partners foster multi-sectoral partnerships, including the youth and a community organization, to strengthen early diagnosis and reduce the stigma around the dementia and also the Alzheimer's disease itself? Thank you so much.
Great, thank you. I'll take those three and then we do another round. So we've got women, data, and governance.
I can maybe start with women and also tap a little bit into hearing and vision. Basically, just to say, watch this space. So menopause or hormonal replacement therapy, as well as a treatment of vision and hearing loss, are being included in the upcoming WHO guidelines for risk reduction. So we are looking at the evidence for those. Maybe I
Sure.
just say, take your question, is it's already great having your federation's engagement and active engagement at World Health Assemblies, for instance, kind of like being there, being active, reaching out, and kind of also reminding everyone of the training needs that you have in order to provide future care. We need you. And I think knowing that we can count on you and you're ready is already very.
Thank you for tackling two. Chris, could you do the metrics, the data question?
Sure.
About that map.
Part of that is the graph was all age, so age structure is not there. But there's also another dimension, because even if you look at age standardized, you may not see exactly the pattern that relates to the risk factors. And in general, when you're studying dementia, it turns out to be quite a bit harder than we like to think to distinguish vascular dementia from Alzheimer's or mixed. And the risk factors for vascular, of course, skew to the north because of all the risks that we know about around diet and blood pressure, et cetera. So there's a little, we do struggle in reality to separate the dementias into those bundles, but most of it is an age structure issue.
Well, thank you very much. I'm sure you'll get the opportunity to grab our speakers at the end of this symposium, of the event. Teresa, I would really like to give you the opportunity because there's a part 2 of the Alzheimer's decision game. Would you like to?
We will be.
We'll be very quick.
Super quick in this. If you could scroll down and press continue. Yeah, so once again, get your phones out, and if your screen has gone black, go to the QR code there. And now you have the opportunity to reprioritize. You've listened to all of the different speakers, and once again, you're doing a prioritization of these different categories. I'm not going to give you the whole time because we're going to move quickly through this. So let's say you've already only got 10 seconds left. I can see some of us are able to get into it. We've got things moving around. Well done. All right, please press continue. Advocacy challenge. You meet with a coalition of 80 advocacy organizations. They appreciate the progress so far, but ask what can be done next. Share treatment outcomes. So this is a choose one. Launch an equitable engagement program or form a standing AD advisory committee. Just another 10 seconds. Okay, continue, please. International Summit. At a global AD summit, some delegates say it's still too early to assess the full impact of your decisions to date, but they want to know which areas you plan to prioritize next for your AD strategy. Once again, it's these same categories. Oh, we're sliding all around between early diagnosis, innovation, public awareness. Another 5 seconds. Looks like we're sticking with early diagnosis. Okay, continue, please. Continue. Your legacy. Okay, your time as health minister is ending, and you have one final move in AD which could help define your tenure. Which legacy will you choose? Publish a 10-year plan or a roadmap, make AD a long-term priority, or create a national AD outcomes dashboard and data platform. Another few seconds. Okay, continue, please. And continue. All right, here's where we are this time. Now we've shifted things up a little bit. Early diagnosis and screening, high on our list, and innovation was the lowest. And then in some other areas, we can look at specific stakeholder engagement. I know we're already over time, and as a streamed platform, we need to move on and stay closely on time. But thank you, everyone, and I'll pass back to Alexia for some final notes.
I'll just extend my thanks to everyone also for participating and staying until the very last minutes of this really insightful round. Thank you very much to all of my guests. I was delighted to hear from all of you. I'm sure you'll be around for a couple of more minutes for those of you who didn't have the chance to ask their questions. Thanks again for joining. Enjoy WHS and see you next year.